Welcome to Inside the Studio, the official podcast of the Texas Heart Institute at Baylor College of Medicine. I'm Dr. Joseph Rogers, and together we'll explore the ever-evolving world of cardiovascular care. In each episode, we bring you conversations with the people shaping the future of heart and vascular health, cardiologists on the front lines of patient care, surgeons performing groundbreaking procedures, and scientists leading discoveries that will change medicine for generations. We'll also highlight perspectives from international leaders and community voices who share our commitment to preventing, diagnosing, and treating heart disease. Whether you're a physician, a researcher, a patient, or simply curious about the latest in heart health, this podcast is your inside look at innovation, education, and care at the highest level. So let's step inside the studio. I'm Dr. Joe Rogers, and I'm the director of the Texas Heart Institute at Baylor College of Medicine, and I'm joined in the studio today by Dr. Joe Coselli, who just has given grand rounds. Dr. Coselli, an internationally recognized expert, particularly known for your work in aortic disease, but just a spectacular colleague, friend, and clinician. Joe, thank you very much for taking the time to join us in the studio.
Yeah, well, thank you, Joe. Appreciate everything.
Absolutely. Well, so many questions after a wonderful grand rounds where you walked us through the history of aortic valve replacement and with a special emphasis on valve-sparing procedures. And it was really... I'm always struck by the nuanced changes that surgeons make to operations. And I asked you this question, during the Q&A portion of your talk, but how do we go about accelerating knowledge generation in cardiac surgery? Are we at a place where we should start to do trials looking at the different kinds of repairs? And then how do you correct for what you highlighted, and that is surgical expertise?
No surprise. Great questions. Probably don't have really perfect answers to elucidate the answers to these broad questions that you would like. But I just go through a couple of things. One, even Tyrone David agrees that to take Marfan patients and to do a prospective randomized trial of valve sparing and Bentel operation, this is simply not going to be done. They come to the table, and if they have normal cusps, they want a valve sparing operation. It's not something that you could prospectively divide up. Try to make the point that for most operations, very rare to be different. For most operations, it's an evolutionary process with small changes which are inspired and make things better. Occasionally, we'll go down a blind alley and things don't work too well. But for the most part, most of these changes are for the improvement. And for all of us, there's a lot of nuanced differences in how we do these operations. I talked about the 6 subannular sutures that I use. A lot of people use that. Duke Cameron, who was at Hopkins and went to MGH and back at Hopkins, he uses 3. And it seems to do fine with it. Probably a lot of his patients, and he does a lot of children, maybe that makes a difference. And he actually got the idea from one of his fellows, one of the residents, suggested it. They gave it a try, probably didn't go to the dog lab, but they gave it a try, and it works very, very well in his hands. Dr. David uses 8 to 12, probably more 10 to 12 than 8. I use 8 for bicuspid valves and 6 for tricuspid valves. He worries about enlargement of the aorta underneath or between those stitches. But actually, when you put in 6, if you've got a 23 annulus, et cetera, when you're done, there's really not much. With 3, I'm not sure, but with 6, there's really not much tissue there to be a problem. And I've always thought, and I started using 6 very early, but when I put in 10 or 12, I thought it was way too crowded. And so, but these are just small changes that. Everybody's played with trying to create sinuses. My opinion is when you use the sinus of Valsalva graft, the intercommissural triangle ends up being effectively almost, if not virtually a straight tube anyway, and you have the benefit of the sinuses. One of the criticisms of it also is that when you're reconstructing the valve, tissue inside the graft, that it's really designed for a specific size and doesn't allow for the variations between the three commissures, etc. So I have not really found that to be a problem. Actually, you can trim it up, and it's actually quite accommodating. I think both of them work very, very well. Some of the guys here at our own institution use straight grafts. I use a straight graft from time to time, but it is what it is. It's a big deal to Tyrone for some reason. He will not give a talk on this subject without spending half of it about that controversy.
So many times we see at least intermediate, many times long-term outcomes with these different kinds of surgical approaches. Do we actually have a good sense with some of the variations that you talked about as what happens from an imaging sort of standpoint? And would we be wise to put together an imaging consortium, to follow these patients serially and longitudinally to sort of get to some of the issues that you just raised? And that is, you come out of the operating room, things look pretty good, but certainly there must be some differences based on everything that you talked about in the remodeling of the various components of the aorta.
Very good question, and I think the imaging techniques now are becoming more refined. It's probably going to help us answer some of those questions. A lot of it depends upon, we're just visually looking at the cusps and saying we think these are going to last 20 or 30 years. Obviously, we don't really know, but if they look fairly normal, that's probably a pretty good guess. If they look really horrible, like I tried to show, that's not a guess at all. You're pretty darn certain that that's not going to hold up. But there's a lot of gray area in between, and it would be very valuable to have imaging studies that could preoperatively sort that sort of situation out, and we could be more precise in what we offer people. What we thought in many cases is one thing turns out to be subdividable into a spectrum of things. For instance, when we finally got the fibrilin gene, everything looked like a Marfan patient, and finally, Hal Dietz and Bart Loeys came up with there's the TGF beta issue, and these are actually, Loeys Dietz, and they're genetically completely different, and their risk profile is completely different. And as Dana Milowitz will point out, Loeys Dietz is not just one thing either. There's anywhere from 4 to 6 subcategories, some of which are at very high risk early on, and then some of them actually, handle the stress of the aortic cusps and the aorta fairly well out to behave more like a Marfan patient. So we're continuing to refine how we see these patients, and that actually affects our decisions on whether or not to save the cusps with valve sparing, how much aorta to take out, and very importantly, when to take it out. It's also, if you're going to take out a relatively small aorta in a patient, your results have to be really darn good, because a lot of these issues that we look at, we see the numerator, but we're not really sure of the denominator many times.
The other thing that struck me in your comments, you showed some of the society recommendations about the level of expertise that we should be looking for. And, in each one of those recommendations, it talked about surgical expertise, surgical experience, the team of people, and it's very similar to what you see in the mitral valve repair space. And, I guess I would be interested in your perspective for people watching who can send patients to a variety of different surgeons. Like how does a cardiologist know where to send the patient?
Viewing things like what we're doing right now might help a little bit, but we have hundreds of publications on these things, both both in the surgical literature as well as in the cardiology literature, as well as in the textbooks. Speaking opportunities. We have meetings where we have cardiologists and surgeons all in the same room. So, I think if cardiologists are cardiology groups, what I think is a good model is that the ones with hereditary aortic issues probably ought to go to one of the cardiologists, who then becomes more knowledgeable of that situation, kind of like they do with rhythm, et cetera, et cetera. And then he should take the time to familiarize himself with what's available for the patients who have reached a level of treatment that, where to, in his location, where to send these patients. It is interesting that all of the recommendations and the guidelines focus on the patient needs to be a young patient. The cusps have to be in good shape. It's for patients with, with aneurysms, but it's important that they need to be done by an experienced surgeon in an experienced center. And even with all of that, except for one of the guidelines, there's still just 2A or 2B recommendations with level of evidence at best B and mostly C. Yeah. Again, we don't have prospective randomized trials on these things. That's part of it. There's, as I tried to show, there's a fair amount of meta-analyses now. They're becoming more available.
How often do you get into the operating room or go into the operating room with a plan for a patient and have to change it based on what you find? And if that's a common occurrence, are there things that my side of the house could be doing differently, information we could be giving you that would make the surgical planning more accurate?
There's some basic tenets, and if they meet those tenets, then the chances of changing what you do at surgery is actually very, very small. You probably got a 95+% shot at doing what you're plan on sparing in this case, doing aortic valve sparing. The cusps can't be calcified because they've got to be pliable. So that if on the echo and the CT scan the cusps are pliable and not calcified or scarred or retracted, etc., you've got a pretty good shot at it. The other thing is, if the root is not too enlarged, we try to get to these patients, in Loeys Dietz at 4.5, and in Marfan patients somewhere around 5.5 at the most. When they get to be 7 centimeters and the annulus really gets big, those leaflets are really stretched out. I showed some on my, in my talk. So if you've got those patients have wide open AI, the chances of sparing those leaflets are small. So if you've got a competent, non-calcified, non-retracted leaflet, you're 95% sure what you're going to be able to do.
You spoke a little bit about the external wrap. I think it was the
pairs operation.
The pairs operation,
yeah, right.
Yes. You mentioned during the Q&A comments about the endobental, which might be an endobental, but maybe not. What is your perspective on what the future looks like for maybe less invasive kinds of approaches to the problem?
We've got a long way to go. I applaud people trying to address that. I talked to one of my colleagues at Stanford. They looked for 6 to 8 months to try to find a case that they thought might fit an endobental, and they do a lot of aortic surgery. They hadn't found one at that point. I just think with material engineering and with innovation and a lot of really good minds working on these things, I think probably eventually somebody will solve the problems that we face with those things right now. The coronary arteries being, the real important issue there. If it was just a valve and a tube, it would, that'd be a done deal. But that's, and then again, for a lot of these patients that are, 30 years old, when you're talking about an endobental, you can be talking about a tissue valve. That may not be the right thing for people if you're going to replace them. And if you do an endobental, you're not going to have the opportunity to do a valve sparing operation on them, which really would be a good solution. But I think in certain circumstances, acute dissection, people with a lot of comorbidities, there's going to be a role for it. But I think the innovators and the engineers and the materials and things are just not quite there yet. But I applaud people trying, and I think eventually all those problems will be solved. Not today, not tomorrow, but the future's always promising.
Listen, I once again just want to thank you for taking the time to do grand rounds today, but also to spend a few minutes with us here in the studio. It's really a pleasure, and we'll look forward to getting you back to talk to us again, in the next couple of years. Thanks again, Joe.
I'm deeply honored, to tell you the truth.
Thanks very much.
You're very welcome.